So this is the slide that I was alluding to, that what's really changed in the last 5 to 10 years is our knowledge of what happens with mouth breathing compared with nose breathing. Okay. So the oxygen molecule is the same going in your nose or in your mouth. It's the same molecule, but how it's processed is different. So when you mouth breathe, it's how you breathe if you're having a panic attack. It's upper chest breathing. I want you all to take a big nasal breath. And what did you notice? Your diaphragm contracted, your lower chest and your tummy expanded. And I tell patients that your lungs are not a cylinder, they're like a pyramid, where you've got a lot more real estate down the bottom than the top. So you're going to get a lot more alveoli filled with air if you nasal breathe compared with mouth breathing. Okay? So that's the V, that's the ventilation component. Okay, what's the Q? The Q is the flow. All right? We've got a blood pressure to go up against gravity to perfuse our brain, otherwise we collapse. But in fact, most blood flow goes downwards. It goes down by gravitation. And so we want the blood to go to where the oxygen is, to have this beautiful pickup of oxygenated blood to go around the body. So that's the VQ. Okay. The other cherry on the cake is that nitric oxide gets concentrated in the sinuses, and when you breathe inwards, you get intraleum nitrous oxide, which has a vasodilator effect, which is almost like like a turbo or a choke on the car to further improve that whole VQ match. But otherwise, you've got mismatch. So we know that nasal breathing is incredibly potent and significant for your whole health, let alone for what you're doing for your mouth and your teeth. So now we're getting to the sort of the nuance of really what I wanted to talk about, because you can all look at checklists and work out whether they've got nasal problems or sleep and behavioral issues. But when do we come into the picture? Well, we only have jurisdiction to insist on airway surgery if A, there's incipient airway catastrophe, you've got tonsils meeting the midline and you're virtually going blue, all right? Or you think there's cancer there, which never happens in kids, almost. So those are what I call absolute interventions, absolute indications of intervention, where I say to you, this is what's going to happen. This is what has to happen. All right, we're going to scramble the jets. We're going to get ready for a swift ambulance ride to the operating theatre. We're going to chaperone you like with F-111s coming in, and we're going straight to the operating theatre, and you have an operation within half an hour. Right? That's the only time I can say you must have an operation. Dentofacial considerations are still only a relative indication in the overall hierarchy. Now, we know that your airway still trumps your teeth. You know, we talk about A, B, C, D, dental, all right? A is still the airway, all right? But I can't insist that you do something unless there's an imminent airway problem that is of catastrophic proportions, okay? So the judgment issue that I think you need to ask yourself is A, how good do you need the airway to be? B, how likely will it negatively affect your results? C, what are those patients' expectations or parents? D, do you insist on it being improved at the very outset of treatment before you embark on treatment? And E, will you potentially be backed into a corner with later recommendations? In other words, you started the treatment, you realize it's not going so well, and then you've sort of had to sort of pivot to say, actually, I think I need to bring someone else in. Whereas you look, I think, really good if You say, look, these are the things I need to get the optimal result. Problem is that everything we do has an upside and a downside. And this is the balance, this is the nuance, this is the juggle of what we do. And it's not prescriptive, there's no formula. You just have to read the room. And I think if you've got a parent's expectations that they're going to get a great result and they're giving you ordinary ingredients, you're better off letting that one go through the keeper. As I said to Simon, you don't need to score off every ball in cricket. All right. We say we make our living on the patients we operate on. We make our reputations on the ones we don't. Knowing when to say no or defer is as important as knowing what to do. Okay. And I think that's probably the most important slide that I want you to think about. Do you need to have the airway improved to get the results that you want to get? Okay, because you're the expert in the dental field. I'm only giving you the ingredients so that you can do what you do. All right. I tell people that the dentist is basically the chef. All right. They've got the equipment, they've got the recipe, but they need good ingredients. And the better ingredients I give them, the better they will do. And not only will their results be better, but the chances of maintaining those results will be better. So the other thing I want you to ask is, okay, how bad is this kid's breathing? What's their functional reserve? Are there any confounding anatomical issues? And we've talked about this before. You know, we're now in a very multicultural society, and there are significant skeletal differences in racial groups. For instance, people of Asian backgrounds have flatter malar and narrower nasopharyngeal openings. People of African heritage, okay, they have obviously, a lot of them are very, very tall, but they have significantly receded jaws. They're very retrogenic. And so then they get the retrolingual problems. Okay, so anatomically, they're much narrower. So you've seen saline flushes. We can give people steroid sprays. We can give them steroid douches. We can check for allergy. We can do some RAST or skin prick testing. Immunotherapy takes about 3 years, but let's look at some of the anatomical issues. Let's go to the meat of this. So there is a nose, and we've got the left side of the nose here with the inferior middle turbinates. And what can we do? Well, we can tweak the septum across, moves it a little bit, but it'll probably move back. We can do septoplasties, but we rarely do them in younger kids. You can, I've tried. It's an absolute bugger of a thing, not because the nose is really small and we're worried about cartilage or growth problems, but just because post-operatively trying to deal with these kids and suction their nose and clean it and manage them is very, very difficult. You can tweak the turbinates out. You can do a little zap of the lining of the turbinates. You can do radiofrequency treatment, or you can even do what we call a powered reductive turbinoplasty, which is where we use a little shaver apparatus, fill it out, the bone. And this is the Cura system. This is for radiofrequency. Here we get the probes. These are non-disposable, so we can sterilize these. It's one of the advantages over some of the disposable ones, which are quite expensive. And there you can see where we're zapping the inferior turbinates to induce an electrical burn. It's bipolar radiofrequency, so there's a lot less heat, but you can still get osteitis and bone exposure. And you can see there, pre-op, post-op, you get the shrinkage of the turbinates. That's some adenoids, the back, and this is where we curette the adenoids. So we're taking them out with a curette. You can also do them transnasally with a shaver. And Adenoidectomy is one of the least sexy operations I do, but it's one of the best operations because the adenoids is at this junction between the ears, the nose, and the throat. So if you can unblock the nose and take a cork out of the back of their nose, the kids are going to do well. So it's one of the best we do. We generally do it between about 18 months and 4 years of age. We do it transorally. I apply some gauze at the back of the nose with some hydrogen peroxide, with some Narrapin as well for a bit of anesthesia. I cauterize the base. I haven't used a sucker diathermy in about 12 years. And then we go on to the tonsils. And some are really big like this with, and don't forget, that's with a kid awake. So they're upright and awake. You know, how congested are they going to be when they're asleep and lying on their back? And another of the little sort of telltale signs is if mum says, oh, little Billy likes sleeping on his tummy, that's always a big telltale, because what the brain is doing is flipping them over onto their tummy so that the tongue will fall forward, because otherwise when they're back, they're virtually obstructing.